Hello and welcome to this Institute for Government and Novartis event on what kind of reform is needed in the NHS. My name is Nick Davies and I'm a Programme Director here at IFG. The Labour government has inherited an NHS that is, in the words of Wes Streeting, broken. Pre-existing challenges of growing demand, an ageing population, and high levels of staffing vacancies have been exacerbated by the pandemic, resulting in very high backlogs and waiting times. Hospital funding and staffing has actually increased substantially in recent years, but that has not been enough to turn performance around. Labour, as part of its first budget a few weeks ago, announced £23 billion of additional funding for the NHS in this year and next. In our analysis, that's enough to help stabilise the immediate crisis, but not enough to set it on a sustainable long-term path. For that, much is resting on the 10-year plan, due to be published in the spring, and the ability of government to make three shifts: from hospitals to communities, from treatment to prevention, and from analogue to digital. So what changes will be required to deliver that reform agenda? Are integrated care systems working properly? Should they be reformed? And how successful have past NHS reforms been, and what can we learn from those now? To answer those questions, I'm delighted to be joined by a great panel. We have Paul Corgan, Expert Advisor at the Department of Health and Social Care, Penny Dash, Chair of NHS North West London Integrated Care Board and leader of a recent review of effectiveness of CQC, Thomas Colston, Corporate Affairs Lead at Novartis UK, and Rachel Wolfe, Founding Partner at Public First and co-author of an IFG and Public First report published last year on NHS productivity. Each of our speakers is going to make brief opening remarks. I will then ask a few questions before opening it up to the audience. If you are watching online, then you can already start submitting your questions now via Slido. We will be live tweeting from the @IFG Events account using the hashtag NHS Reform. Right, with that, I'm going to hand over to our first speaker, Paul Corgan.
Thank you. I've got three things to say about the 10-year plan for health. The first is, people will have noticed when we announced this 2 or 3 weeks ago, there was a strange reaction, like, why aren't you just doing this, rather than actually talking to us about it? Not everybody, but there was a distinct political reaction. And it's quite, so a political party, as far as they're concerned, should come into government with a plan that it just does. I've got 2 words to say to that: Andrew Lansley. And that because we do have a world experience of that, and the necessity of engaging with the public is because if you are going to change the nature of the model of care of the National Health Service, and you don't engage with the public about what you're doing, I promise you they would notice when you change the model and have not talked to them, and they will not change, they will not go along with that change if it is something they're not a part of. So this is not a simple piece of ideology that we need to talk to people. We need to talk to people because the end result is going to be some form of change in the model of care, and they need to be a part of that because they'll be a part of the change in the model of care. I'll come back to the number in a minute. There's 1 million consultations every 20 hours in the National Health Service, and that means there's 1 million relationships every 20 hours between the public and the National Health Service at the business end of it. And if we change the nature of that relationship, they will notice. And doing that in a room and not telling them is a disastrous thing to do. And my second point sort of makes that point. The 3 shifts that the chair mentioned, which is hospital to home, analogue to digital, and treatment to prevention, are shifts that have been part of the planning for NHSE in 2014 and 2019. There's virtually nobody who disagrees with those 3 shifts, and the most significant thing about them is they keep on not happening. So the nature of the plans that have constructed these, that have outlined those things in the past, it's not that anyone disagrees with the outcomes, but the nature of the change that's necessary for those three things is a profound series of changes, again, I would say, in the entire model of care. So it is no good just coming up with another 10-year plan or another 5-year plan that doesn't happen, because, as the chair said, the reason for doing this isn't because you like to change and we just like to fiddle with things. The reason for doing this is the amount of care that is going to be necessary in the next 10 to 15 years with an ageing and sicker population will overwhelm the current model of the National Health Service. Not might do, will overwhelm the current model of the National Health Service. So doing nothing and just planning and not implementing is not a part of it. So the third thing is coming back to the 1 million consultations every 20 hours. When you say to people, what you're going to do with this plan, well, the thing is, in 2035, those 1 million consultations, every single one needs to be different. That's a big change program. There needs to be an element of that interaction in one way or another, which is a different form of interaction that takes place at the moment. There's a whole variety of ways in which that might happen. It's almost certain that technology will be held by the patient and will hold much more of their health and healthcare. But the major thing that's going to have to happen in all of those consultations is at the end of each consultation, the patient will need more agency than they have at the beginning, because they will need to have more involvement in their health and their healthcare than they have at the moment. That is quite a radical change. And I'll just end by talking. I'm quite handy as a teaching aid here because I'm the same age as the National Health Service. So I grew up in the post-war period as part of a period when my parents' generation were wondered at how great all of these things were. Because I grew up in a home where the state owned my home, the state owned my education, the state owned my health. And as far as my parents' generation is concerned, that's fantastic. As I grew up, I went to the London School of Economics, which therefore won't surprise you that I didn't like the state owning my education. And under those circumstances, over the previous 60 years, I've learned that different things belong to me and not to the state. The same is true of health, and the same is true of healthcare. But in 2035, the model of the state ownership of these things will not work. The model, if you combine the state ownership, a nationalised industry of healthcare, and you do that, you combine that with medical knowledge, you have an immense asymmetry between the person on one side of that consultation and another. And it's that asymmetry we need to do something about in the next 10 years.
Thank you. Pennydash.
Thank you. So I'm very much aligned with Paul that I think over the next 10 years there is going to be massive change. And my only concern really about the 10-year plan is the inevitability that how can we possibly know what 10 years out will look like? Because of course we can't. You know, certainly the pace of change of technology and so on makes that very hard. But what that also means is, and with all due respect to where you started, I don't quite buy all this analysis at the moment that says, oh, there's not enough of this, there's not enough of that, there's not enough of the other, because we're going to a very different place. How can we possibly know? That analysis is always based on the same model of care that we've had for the last 50 years, which is largely around human beings interacting with other human beings, and we're on the cusp of things looking very different. So that's just a little bit of a preamble. You asked quite specific questions, so I'll try and give quite specific answers, and I'll focus on specifically the things that we are trying to work on in North West London. We've got 2.5 million people that we care for, as it were, but again, rather old-fashioned term that we're responsible for, trying to help them improve their health and ensure that we provide high-quality services. And we have a budget of £6 billion a year to do that with. So I'll stick with the 3 shifts, but then I'll add to that. So 3 shifts, clearly, you know, as Paul said, people have been saying it for years, it's sort of almost rather obvious, isn't it? But it's actually useful because what we haven't had really that much of for the last 10 years is a clear framework. And I say, hallelujah, we've now got a clear framework. So I'm going to stick with that clear framework. I don't feel a need to change it. I think it's a good framework. So absolutely, do we need to do more on prevention? Of course we do. Got well over, whatever we're up to now, 60, 70% of people are overweight and obese. Smoking is going back up. We never talk about breastfeeding anymore, even though that's one of the most important interventions anyone can do. We're at the bottom of the world league tables on that. We are not in a pretty place when it comes to prevention, so we need to do something on that. And I think we need very different approaches and solutions and ideas around it. I'm hoping that those will come out of the 10-year plan, or a number of them will. Secondly, the shift left. So again, people have been talking about that for years. We are trying again in North West London to try and move forward on this. One of the things I think one of the biggest impediments we've got is it means different things to different people. And it's very easy for people to say, oh yes, shift left, shift left, shift left. And there's quite a sort of slightly amusing thing happening in the NHS at the moment where everyone goes, oh yeah, shift left, shift left, shift left, just don't touch me. You can do all this shift left, but it's nothing to do with me. Well, if the hospitals don't want to be part of it, if the GPs don't want to be part of it, and if the community and mental health teams don't want to be part of it, I'm not quite sure what it does mean. So I think we've got to be a bit more grown up and honest about that and say, well, first of all, we've got to describe what do we mean by it. And I do think the concept of a neighbourhood team is a concept which seems to gel well. It has a lot of evidence-based and analysis behind it, and it's got some pretty good prototypes that we can look at in other countries. And if we look at and indeed we've got some early adopters in this country. And if we look at the sort of concept of and I do think there is something about a facility, though an awful lot being networked as well, a facility that you can walk into 14 hours a day, 7 days a week. You can have good wellness support. You can go and use an automated blood pressure monitor. You can join a healthy living class. You can join the diabetes group consultation. You can see a GP. You can see a pharmacist. You can get your drugs, all the rest of it in one facility, and you know it's there. It's got the lights on and the doors open. What's not to like with that? And that is entirely within our gift. Entirely. We could roll out that model of care within probably a few weeks in North West London if we could get the support to do it. So we've got the buildings, we've got the staff, we've got the facility, we've got the concepts and so on and so forth. We could do it. So that's, but we've got to be willing to do it, and we've got to tackle some vested interests, and there are plenty of vested interests which make it difficult to get there. So that's the shift left. And of course, if we could do that, I think we would absolutely have better care for people with diabetes, with heart disease, with frailty, and so on and so forth. And therefore, we could reduce the number of people turning up at our acute hospitals. However, the number of people turning up at our acute hospitals in North West London hasn't actually grown much in the last 10 years. Despite what one might hear and one might think. So yes, we can definitely do a better job, and we could definitely do an even better job of particularly keeping older people with frailty out of hospital, because not many people who are old and frail and have dementia want to go to hospital. So there's a lot to play for on that, but let's not kid ourselves that there's this mythical number of hundreds of people turning up in our hospitals and so on, because there isn't, which has been a good success story. So therefore, we flip to the analog to digital, and that's a good buzz phrase. And we absolutely need to get on and do that. And the power of the digital tools out there is phenomenal. I mean, absolutely frame breaking, completely frame breaking. One tool developed at Great Ormond Street by a cardiologist is taking out 10, 20, 30% of the time of each consultant in each outpatient clinic. And they're doing that today with one AI tool. We only need to add 5% of capacity to outpatients to not have a waiting list in a year. And this one tool is giving a 10, 20, 30% productivity improvement. I mean, it's absolutely phenomenal. And you look at some of the other things out there, they're of similar scale of magnitude. So the challenge is not really finding the technology. The challenge is really thinking about how do we adopt it? How do we integrate it into our current ways of working? And how do we then capture the benefits? Because if we continue to schedule all our outpatient clinics as being 30 minutes for a new and 15 for a follow-up, you're not going to get the benefits. And that's a bit of what's happening at the moment. And so therefore, we've got to do the operational improvement off the back of it. And the biggest thing missing, I would suggest, in the NHS at the moment is operational management. If I could do one thing, it would be to bring in great ops managers. Because what we've done, again, over the last 5 years with very good intention is we've added an awful lot of staff. You can see that in the IFS reports and so on. And why haven't they had the impact that we would have all hoped is because a lot of that operational management discipline is not there. And you can see that, people will tell you that anecdotally. You can go and look at it. You can go and see, the empty outpatients and then the busy one next door and, da-da-da-da. So ops has to be the focus for the next, I would suggest, next 1 to 2 to 3 years to sort out the operational functioning of our hospitals and so on. As we're bringing in the technology, so we adopt the technology into that, use that expertise to get it interwoven into those core pathways at the same time as we're developing the neighbourhood care, neighbourhood teams and so on, and that gives us the model of care that we want. But if we're going to do that, we've got to address many of the underlying things as well. So we need really strong commissioners in the form of ICBs with the skills and capabilities to do this work and to use data effectively and to understand the scope of digital tools and so on. Secondly, we need a very different offer to the workforce. Many people are disillusioned at the moment. It's palpable. We need to think through how do we re-energise, re-engage people, offer people a great employment opportunity, offer real opportunities for those who want to do more and so on and so forth. We need to think hard about competition. I'm all in favour of competition, but we haven't addressed what do we do with the people who are losing activity as a result of competition. So there's a lot of work taking place now in private providers, elective surgical work, but we've still got the capacity sat, both staff, facilities and so on, in our NHS hospitals. We can't run all of this. We need to think through that. We need to think through failure regimes. And ultimately, we need to think through, as Paul said, what does all of this mean for users, members of the public? How do we change that whole model of engagement from an old-fashioned one that we can all describe to actually something much more energised and engaged and so on, as Paul was describing?
Thank you. Thomas Colston.
Thank you, Nick, and thank you to the IFG for convening today's event, which we're very happy to support. So Novartis, briefly for you, that don't know, we're a global life science company working across a range of therapy areas and platforms, and we've got extensive profile here in the UK, working from clinical research through to NHS partnership. So on what reforms does the NHS need? As you mentioned, we've had in this country, in recent decades, lots of experience, and things have worked well and things have worked less well. I thought what I'd do is offer some thoughts on the how of reform and how you might go about this as a government in the future. Firstly, and as Paul will tell you, reform is very hard. It takes time to deliver improvements, and you may not be there to see the improvements when they do come. And reform creates winners and losers. The winners will give the government very little support, and the losers will give you a lot of opposition. The best reforms, to my mind, over recent years, as everyone in this room knows, the health system is a very complex thing. And the best reforms have been those that sought to simplify the system for patients, providers and professionals. And it's often the case that governments can come in with new initiatives, new programs that no matter how well intentioned or thought through, can just create more complexity in the system and hold back that improvement that would otherwise happen. The reform needs to hit the front line. Sometimes we think you can isolate reform just to managers and structures in the system. But as Paul mentioned, when all else is equal, the NHS is millions of meetings between doctors, nurses and patients trying to improve care. And if the reforms you're trying to introduce are not changing that, what are the value of those reforms? You need to empower leaders in the NHS, and it's much easier said than done. The true test of any reforming minister is, can they let go of the system, and can they genuinely empower leaders in the system? The Hewitt Review a few years ago was very honest that for ICBs to evolve and improve, ministers must stop interfering and have a simpler set of priorities for the system. What else I had? The voice of the patient is so important, and as Penny mentioned, there are lots of voices in the NHS. Voice of the patient is perhaps one that's often overlooked. And we've tried many things over the years to try and improve that voice of the patient, whether through choice, for more information, created new bodies to champion patients. All those things are worthwhile and good, and more of it would be welcome. The best reforms had clarity of purpose. Thinking back to the 2000 NHS plan, there's lots in that, but when you scale it back, the one thing it was trying to do was to reduce waiting times. And I think reforms that can articulate a very simple and straightforward goal have the best chance of succeeding. What else on my list? We need to talk more about incentives in the NHS. Often reform, we get focused on changing bodies, renaming bodies, reordering bodies. Much harder to look at funding flows and incentives and have much more impact. You must get the narrative right. As Paul mentioned, the last government brought reforms forward without making a case for change. This government had tried to do that for the Darcy review and some of their quite bold language on the state of the NHS. You also need to focus on outcomes, not inputs, and also balance both lofty goals and also manage expectations. And this government talking about the biggest reforms ever in the NHS, but also the fact that waiting times won't improve in the short term, have done that quite well. And I think those are sort of the main ones on my list, but I look forward to the Q&A. Thank you.
Thank you. Rachel.
Thank you. I think, unlike the rest of the panel, I have not spent my entire career in health, so I thought I'd start on a slightly more macro picture. How many of you played the Financial Times' Be the Chancellor game before the budget? I figured this room, if any, it would be loads. Right, only a few. Which is basically a very well-designed game to show you how stuffed Rachel Reeves was before she stood up. Asks you to set taxes and spending, and you have a helpful advisor who pops up on the left if you make things, if you cut spending too much, to say that you're going to lose the election, and a helpful advisor on the right who pops up if you spend too much to say that the bond markets are going to go crazy. And on one of those pages were the health spending and the education spending as the main sources of domestic spending. And there was a default in the centre, and the default number for health was 3.6%, and the default number for education was 0%. So if you went down in health to say like 1-2%, your advisor popped up, you could stay at 0 in education and no one said anything at all. And that was a very accurate reflection of how spending tends to happen in the UK domestically. Of course, at the same time as the OBR's current predictions is that we're going to be hitting 1.5% real terms growth in the second half of this parliament, and we just saw that we were at 0.1% for the third quarter of this year. So I thought everything the panel said made sense, but I think one thing, if I'm looking forward 20 years, is I don't see how this dynamic continues. Something is going to have to give. And maybe we will, I hope, we will discover the halcyon days of 4 to 5% growth where we can do as much health spending as we need and pay for all the wars that are coming down the track. But if that doesn't happen, then something is going to have to fundamentally change at some point in the next 20 years about how we do health. And it seems to me broadly there are two choices, and we may end up with both. Choice number one is we ration more, right? Fewer people get stuff in some way or other. And choice number two, which is where I think most of the panel has been going, is that we discover or we allow for vastly greater innovation than we do today. And that can be process innovation, it can be medical innovation. So I thought maybe what would be helpful is to talk about, in the short term and the long term, some of the things that you might do if that's what you cared about, allowing for a fundamentally sort of more innovative health system. And we're, in the short term, I think, in a fascinating experiment right now, because where Streeting, I think, has indicated, at least in pieces, that the way he thinks he gets process innovation right now is by the reintroduction of targets, at exactly the same time as his counterpart in education is saying how furious she is with targets. She wants to return to collaboration in education. So we're going to see which of these results in the biggest productivity improvements fastest. But in the short term, and I'm going to pick up what a number of others on the panel have said, it seems to me that there are lots of ways in which process innovation, indeed ideal process, is constrained. And in our report, Nick, the two biggest, which have already been, three biggest, which have already been factored, are we have quite a ballooning very top level of management in NHS England. If you look at the number of FTEs in NHS England over the last decade, they've gone up very, very impressively. But at the hospital level, certainly, the level of operational management is woefully low compared to any plausible comparator, whether in health or any other part of the private or public sector. So we do not have, in your kind of classic productivity of capital, labour and management, the management bit is remarkably low in our health system, and improving that seems to me a plausible way of increasing productivity. And the other bit that's kind of relatively low is the capital bit. We have poured people into particularly our hospitals, and we haven't done very much on either the management or the capital side. But the other thing that I would say we've done, and I think this is partly what you were talking about, is we've made the whole process of managing that much more sclerotic. We have far more layers of targets than we used to. When we talk to doctors and people in hospitals, and I'm sure you will know more for this report, the sort of Byzantine and bizarrely unclear process by which you figured out whether you had any capital to spend and what it was and how the hell you got it and was it this year or next year and what was this negotiation going on, compared to what existed in, for example, the Foundation Hospital period, which wasn't perfect but allowed that kind of autonomy and reaction, was remarkable. So there seems to be some basic constraints on short-term sort of productivity that you could look at least in hospitals. But in the long term, if what we're trying to do is completely rewire the way health is done because we think this current spending dynamic isn't working, then I think we have to ask more fundamental questions about what sort of system allows for rapid innovation. And I think usually those systems are not as centralized as the NHS system that we have today. I can't think of a system that allows for rapid innovation that is as centralized as the NHS is today. I also can't think of a system with people as miserable in it that allows for innovation as the NHS is today. If you compare, if we're going to go for sort of more nationalised things, if you compare the sort of pride people have in running the bullet trains in Japan to how most nurses and doctors seem to behave right now, that's quite a stark difference. People need to believe that they have a degree of autonomy and responsibility and health. And the third is that in my 20 years in public policy, and I wish I had a better answer, I'd be interested in the questions, the NHS has never managed to spread anything anywhere. What's the point in having a centralised system if it at least doesn't push things through it? It neither has the autonomy and the responsiveness of a series of smaller units, nor the scaling ability of something large and centralised. So I think we have to ask how you scale those through. I'm sure there are lots of other big ways in which you may need to reorient in terms of where care gets done and how early it gets done and to whom. But that's where I'd start. If we think this is about a fundamentally different way in which care gets delivered and how much of it is technological and what kind of devices and medicines are used, we have to ask what kind of system allows for that kind of innovation to spread and change fast, and I don't think we have one.
Okay, I'm going to ask a few questions before opening it up to the audience. And I think I've probably got questions for all of you on the mechanisms for change. I think there's broad agreement on purpose of the system and on some of the structures, but it's about the mechanisms for change. Rachel, I wanted to come to you first, reflecting on kind of, because you've done a lot of work in education beforehand, and that schools are the one public service where there has been a meaningful performance improvement since 2010, and that was both a kind of greater autonomy through academisation, but then also kind of some central action through the curriculum. What do you think is the right balance? Because one can raise minimum standards and one does create innovation.
Yeah, I think it's a very good question. So for those of you who don't know, the basic idea of the education reforms, which was absolutely building off what Blair and Andrew Adonis did before, which is relevant because I think these things take a while, was to say on the one hand, there were certain things that we expect to be done, which were delivered in three ways. First, through a national curriculum, although not all schools had to follow it. So therefore, much more significantly through an examination system, an assessment system, which measured whether people had hit certain things. But also, and I think this is probably one of the biggest contributors to us raising international standards, through identifying certain small pieces of activity, of which phonics is probably the most significant, that could be easily delivered by any teacher in the country, was easily understandable by parents. You know how to, those of you who have had kids in school recently, it's not that hard to figure out how to do phonics with them, and you see that in polling, they know how to do it, and which were easy to incentivize. So it identified small scalable bits of content. But then above that sort of minimum standard was actually very loose about what schools did, how they formed, how big groups were, and how they behaved in their models. And that sort of combination seems to me not that different from the theoretical combination of the late Blairite medical system. And I think I find it quite annoying as a Conservative that we turned it into a much more sclerotic and bureaucratic and centralised system than we inherited, because that's broadly what education did.
And then, Paul, I wanted to come to you on that, because we obviously had this big Wedge Streeting speech last week, and I wondered if you could say a bit more about what the department's kind of theory is on how you do performance management well. Because on the one hand, he talked about league tables and sacking underperforming CEOs, but then also talked about the problems that a culture of fear can create and the need to decentralise and provide more autonomy. Like, what's the department's thinking on the right balance?
I think picking up on something Rachel said about centralisation, there is an enormous performance management set of activities in the National Health Service. They do all sorts of things, but what they don't do is manage performance. So there's a set of activities, but actually performance doesn't get better. So you can have a massive performance management system which doesn't improve performance. So let's not pretend that, in a sense, centralisation has worked here. And part of the problem is, when I talk to CEOs, is they will tell me there are no consequences. Because actually, if you're good, you get treated the same as if you're not good. So what happened last week in that speech, and in a sense, what NHS has done with its, this is boring, but its operational framework for next year, is to be slightly more rigorous around the nature of the segmentation between 1, 2, 3, and 4. And we thought it might be interesting to treat you as different, because self-evidently, some are better than others. And Rachel mentioned about foundation trusts, which I was involved in more than 20 years ago. And in a sense, what that was saying is, if you're good, the main performance management we need to say is, get on with it. Get on with it and construct your own activity in doing that. And in a sense, part of, I think, the response to how you get innovation is to allow the people at the front to get on with it. And I don't think that's happened in the last 10 years. I don't know why. I don't know why a government... So certainly when we introduced foundation trusts, the Labour Party wasn't very happy about that. But we did it, and then I'm just bemused as to why it goes backwards under a Conservative government. But anyway, it did. So it's the crucial thing is segmentation. And that means one of the ways in which the NHS has talked about helping trusts that need help is generically, it's always called support. So in the second group of people, it seems to me they've got the right to decide whether they're going to get improvement science or not, because they're better than the third group of people who probably don't have the right to decide whether they're going to get it. And the fourth are an entirely different category. So the answer to the specific question you asked about what's to do with freedom and what's to do with hard performance management, it depends where you are. But there has to be a differentiation which everybody recognises is a differentiation. Otherwise, there is no point in the overall performance management. So, in a sense, what was developing, because what is not so exciting in the media, is that they're looking at what on earth would earned autonomy be, which is the phrase we used around foundation trusts for integrated care boards, was actually, how do you say to the front, we think you can get on with it slightly more. So I think the crucial thing in that speech is differentiation.
Penny, you talked about the objectives are right, but there are problems with vested interests in terms of actually delivering. Do you think that kind of differentiation that Paul just talked about is a way of overcoming those vested interests?
Potentially, but I think there are some things that need to happen centrally. So I think to pick up on Rachel's thing, I completely agree with what you're saying. In the heyday of the sort of 2004, 5, 6 up to about 2012, 13, 14, there was exactly the same as you describe in education, I think, what's happening in health, and significant progress in a whole host of things, and actually reasonably centrally driven, to be honest, around this is what good cancer care looks like, good cardiac care, stroke care, and so on, and recognising some of the structural problems which there are in healthcare around that. You cannot provide some of those services in small, low-volume units, and actually that almost, the system at the centre, by putting that out, helped people locally to make the changes to counter the vested interests that were blocking it. And that led to significant improvements. We're in a different place now where, again, there are some bits which are quite big changes needed, like trying to develop the neighbourhood teams, where certainly you can take it so far yourself locally, but certainly what we're finding in North West London is we are hampered, to be honest, by the vested interests that are quite hard to manage locally. So I think on quite a few of these things, you need a bit of national and a bit of local. So, the GP consultant contract, if you've got really great GPs who want to do really good things, you can work with the contract. If you've got GPs who don't, and who are not performing very well, it's really hard. It's real hard yards. We've got one situation with someone with all sorts of allegations of fraud and so on and so forth going through the courts at the moment. It's been going through the courts for 5 years. Judicial review after judicial review after judicial review. And at the end of the day, there's, 10,000 people getting very, very poor care. So there are some of these sort of national, because we have got national contracts and so on, that are problematic. The second is, which is much more sort of hard yards, but I think does require, I think we're all saying similar things, requires much stronger local management, local leadership, ops capabilities, analytical capabilities, deep understanding of costs. So those things are very missing at the moment. So for example, if we try and move, I'll stick with the neighbourhood teams, but we could say even more about hospitals and so on. If we, for example, say, let's try and move to one of these facilities, which would have lots of services in it, co-located to support staff working together and so on, people say, well, I haven't got anywhere to do it. And you say, well, what about that building there? That looks fine, it looks nice, it's brand, it was built 5, 10 years ago. Well. And of course, the well is the crucial bit. So, the ownership will be complicated. There's no acceptance of working in primary care, of working, yes, but of seeing patients between 12 and 3. So most of those consulting rooms in the very high quality, nice, fancy GP practices don't have patients in them between 12 and 3. And then you say, well, actually, that would allow us to use the space more efficiently. You could open on a Saturday and so on. Oh, no, 12 till 3 is lunchtime. Or, that's when we go and do home visits, or that's when we do this. And you say, well, let's shake that around a bit, do the home visits here. And ooh. So this is hard yards, and this is about really good operational management. I'll just keep coming back to that. And I think the fundamental question, which is where Paul was going and we're all sort of touching on, is how do you encourage that to happen locally? How do you incentivise that to happen locally? And is this around sort of opening up the market to new players to come in who, would never occur to them that you kept the space empty between 12 and 3. It's all about footfall and sweating the assets and so on. So is that new players, or is it about letting go to the existing players and saying, we'll liberate you to make some of these changes? And I think it's definitely, well, I think it's both of those, but you can do a lot more of the latter, but you have got to allow people to cut through the treacle, and you've got to minimise, I think, this stuff about planning and some of the stuff around HS2, that is alive and kicking in the NHS. You try and make some of these changes, and the list of things you have to go through, the time and time and time it takes. So in North West London, there was a state-of-the-art elective surgical centre built, which I happened to go round it in 1990. So it was built in 1990, amazing, beautiful building, and it hasn't been used for elective surgery. And then in COVID, we said, come on, this is ridiculous. This would make the perfect sort of cold site for elective surgery. And we did a very small bit of emergency stuff. And then we told, you've got to go out to consultation for this. Took us 2.5, 3 years to go out to consultation to use that facility that was built as an elective surgical centre as an elective surgical centre. And it's still only 50% utilised now. And that's about 18 months since consultation finished. And that's because now we haven't got to agreeing with all the surgeons that they will go and work there and so on. I mean, it's absolutely jaw-dropping the time it takes.
Thomas, a few people have spoken about some of the kind of the characteristics of the approach in the Blair era. And one that you mentioned as kind of helping was the clarity of purpose in terms of reducing waiting times. At the moment, that is still one of the things that Wes Streeting wants to do, but he also wants to make those 3 shifts, etc. Do you think it's possible to reduce waiting times whilst also moving care out of hospitals, making care more preventative?
I mean, when time will tell, I think, if you just sort of look at the reforms government have spoke about, they're trying to do both those things, aren't they? Last week's speech was about waiting times primarily. It felt to me that was looking at acute care performance. The long-term plan, the 10-year plan, is much more about those 3 shifts. The fiscal environment they're working in is constrained, as everyone here knows. That will definitely temper how much can be achieved. I think, I'm sure Paul will say they're all linked ultimately, aren't they? A model of care which is more aligned to the healthcare needs of the future, with more out of hospital care, digital shift, emphasis on prevention, will allow you to deliver acute waiting times more effectively. Now, all that is much easier said than done. We'll see. I think looking at the government's plans as they've revealed them, it's, as people have said, that the 3 shifts there's nothing new, and that's a good thing, right? They're building on what we've seen before, and there's agreement. It's almost unusual, but in policy, but there's agreement between governments and the NHS and the wider health community on what model of care we want for the future. In the government reforms, they've not picked on 1 or 2 enablers. They've recognised that lots of things need to change. Everything from data, finance, infrastructure, workforce. It's a very broad-based approach to trying to move the system forward, which is welcome. And we'll take all those things and a lot of effort behind them. One final thing I will say is that we can often, in any world of policy, get absorbed by the very first stage, the exciting bit where you can throw in ideas, you can consult, you can engage, and there can be a lot of work in the next 6 months with working groups being set up, more speeches from the Health Secretary and others. The hard work will begin after that, right? And how the government maintains this level of momentum, energy and focus next year and beyond, once we've had all these exciting announcements. That will be the really, really important test.
Right, I'm going to open up to questions from the audience. Can you please, I'm going to take about 2 or 3 at a time. Can you wait till the microphone comes to you? Say your name, where you're from, and can I please ask, because I'm sure lots of people are going to want to ask questions, that it is in fact a question, that it's short and is not a long meandering statement. I'm going to come to here, and then to here, and then to here.
Chris Smythe from The Times. As Paul said, the 3 shifts that we're talking about have been policy at least for 10 years, probably longer. So I'd be interested in thoughts as to why they haven't happened. Is it, as well maybe suggested at the beginning, is the public don't want it? Is it a lack of political will? Is it, as Penny suggested, perhaps operational management just isn't there to make it happen? Is there some kind of problem with the financial incentives in the system? Is there an innate cultural conservatism? As some of Penny's other answers seem to suggest, that the culture of the NHS just doesn't allow this. Why hasn't this happened? And to Paul specifically, you talked at the beginning about state in the future, a sort of state ownership model not working. Can you expand on that? What do you mean, state ownership of what?
Thank you. And then 2 gentlemen down here.
Hello, Henry Anderson, Health Service Journal. I'm just curious, primarily to Paul, but I appreciate the thoughts from the others, if you could outline some of your thinking on financial incentives, because at the moment we basically have a system which is payment by results for elective activity and block contracts for mental health, community, etc. So we're kind of incentivising the wrong activity at the moment.
Great, and then up gentlemen here.
It's Andy Cowper from Health Policy Insight. All of the panel seem to talk about the need for real change, delivering real change, and therefore having incentives that are going to support that real change. Probably one of the biggest changes post the Lansley reforms, which Paul mentioned earlier, was what Simon Stevens did in the 5-year forward view, which was essentially to subtly but entirely without any parliamentary legislation subvert it. What does the panel think are going to be the approaches that we will see from the Labour government in terms of how they will deliver change?
Great. So 3 questions there. One on the approach Labour will take to delivering change, one on the role of financial incentives, and then one on kind of why the 3 shifts haven't happened and state ownership. Paul, I'm going to come to you first.
I think the nature of change, just thinking back to 2001, 2002 and that period of time, what I remember in making change happen is, I know this sounds quite a grand thing, is the necessity of having public-facing arguments and winning them. I know that sounds an odd thing to say, but actually the truth is policy is really feeble. And that people don't do much because of policy. They do things because of narrative. And they do things because stories move them to do things. And going back to 2002, I remember the NHS saying choice will never work because the public can't make choices. And that was a genuine belief. And in the end, the public-facing narrative about the public making choices all the time sort of won the day. So I think here we are, in a sense, I suppose, what do plans do? And the answer is very, very little. People do things. And so how you mobilise people to do things is actually, I think, a crucial part of both the way in which the plan is being constructed and then how it motivates doctors, nurses and the public to do different things. And what I mean by state ownership is not, I really don't want a private health company to own my health either. I want to own it myself. Right? It is actually moving away from the medical, not just the medical profession, but a form of healthcare where the ownership is away from the patient. And so it's not just an anti-state thing, it's a pro-patient thing. On financial incentives, I have to say, I can't imagine a plan saying in spring next year, you know, we got the financial incentives all right, we're going to do nothing about it. I don't think that's going to happen. What's going to come out of it, genuinely, I don't know. But actually, the current financial system doesn't work to bring about changes.
Penny.
Well, for the sake of time, I'll just focus on that one. So completely, as Paul, the current financial system is not working. And so there's some really interesting examples of what are happening in different countries around the world. A lot of discussion here. Paul and I were both involved in writing a report last year on some of the different things that could be considered. I think the interesting thing for me, though, is what needs to be in place to make them work, because you can come up with all sorts of different things. So first off is we absolutely need really good data so that we know what's happening, so you're not paying, you know, the same amount for an uncomplicated widget as for doing some major procedure. You need really good data if you're to do more at-risk schemes and so on. So the data is fundamental. The commissioning skills, again, are fundamental. Who's going to actually hold the ring on this and make sure that money does flow to the right places? The third is really good understanding of costs is absolutely fundamental. And as I said before, we do not have that in the NHS, and we've got to get a proper understanding of costs. We've got to be able to account for every single £200 billion and know where it's going, and we can't do that at the moment. And then the final thing is you have to have a sort of success regime and a failure regime. You know, there's no point having any of these financial models if nothing happens. So, you know, as Paul said at the beginning, you've got to then recognise and reward success, and you've got to penalise failure. And that's really, you know, that is difficult for some people, but I think history would suggest that that can have a very positive impact.
Rachel.
So I guess I would just say 2 things. The first is what I think Penny described before those questions were horrifying examples of a generalised problem which remind you that if we just remove some of the scleroticism in the system, the money we have could go much further, much faster, and I don't think we should ignore that. On financial incentives specifically, I think the current system has become incredibly complicated, as if we can magically move ourselves to a perfect set of activity on the front line in every conceivable form. And it is, I think, a symptom of our misunderstanding about what can be centralised and what can be localised. And when financial incentives, to me at least, have worked best in changing a system, it is when you have been willing to be very selective and accept the fact that that's going to have some effects, and maybe some effects that are more blunt than you would like, but it is directing a system in the only way that is possible from the centre. So I think we need to choose fewer things.
Thank you. Thomas?
Yeah, thank you, Nick. I think, I mean, on Chris's question, I think no, all the above and many more. I think it's, you know, so a few years ago there was this a review published by on sort of ICBs by Patricia Hewitt, which, from my mind, was very honest about the challenges of reforming the NHS and what needs to change and how it would, you know, the trade-offs involved for politicians and for ministers. And it was striking that there was not a word of response, from what I could tell, from ministers to that document. And it felt to me that some of the, you know, the trade-offs identified were perhaps at the point in time too much to consider. And I think, you know, it'll be interesting to see how we go through this winter with the NHS. You know, how the Health Secretary starts to look at some of these choices that he'll have to consider. On your point, Andy, about the sort of the model of change, it's just an observation. You know, last 3-4 years, we've got used to discounting the role of the health department as a change agent in the health system, because we focus so clearly on NHS England as the key player in the NHS. And Simon Stevens, to your point, was the main actor in all of that. And it seems to me since July, that debate has switched entirely, that we're now once again obsessed by what's going on in the department, by the Health Secretary, his team, people around him, what's going on, the programmes they're unfolding. And we've almost forgotten the role of NHS England, that actually, when it comes down to it, is the organisation that can deliver change in the NHS more often than not. So, yeah, we'll see how that plays out in due course.
I'm going to ask a few questions that have come in online. Paul, I'm going to put this first one to you, which was, what are the key areas of reform that could support and enable primary care to succeed?
Well, interestingly, it seems to me the three shifts we're talking about all have a relationship with greater enablement for primary care. Not just enabling, but sort of giving them much more say. So if we're moving hospital care to home, then obviously primary care is near to it. There's an interesting thing, as Dudley Moore would say, about the Latin, right? So primary sort of is first. Actually, most primary care is secondary care, because primary care is people looking after themselves and their friends and families doing it. And people go to the doctor in a secondary way. And what we think of as pre-primary care is actually most care that goes on. And having been to the doctor and the doctor giving you pills, you take them at home. So I think primary care is terrifically important, but actually most care is pre-primary care. And making that better is as important as making primary care better. And so I think we will see an enriched primary care, and we are seeing over the last few years, because of additional roles and responsibilities, and as Penny's been talking about, a neighbourhood health team, the people doing primary care will involve a very wide range of people. And in a sense, the move from analogue to digital is one where the public will be much more involved in their self-management because of the knowledge they have in their hand. I mean, you know, all the medical knowledge in the world. And so that what my doctor can tell me to do, I can upload, and have done, my blood pressure monitor, put it onto here, it goes to my GP. I don't go and see my GP. So is that primary care? So the amount of care we can now do from analog to digital, I think is going to be an enormous change.
Thank you. Penny, another question here. We haven't really touched on mental health much so far. How can we reform the NHS in a way that mental health care is given the appropriate level of attention and funding it requires?
So I can absolutely promise anyone that mental health care gets an enormous amount of attention in ICB land, first off. And secondly, if anyone, geeky people, and I know there are several in the audience, like doing analysis, look at our board papers from July the 16th. And you'll see the most incredible in-depth detail analysis of mental health care and what the money is spent on. And you'll also see an enormous opportunity to redesign it.
Thank you. Rachel, I'm going to put this one to you, which is from Hemant Verma, because I think you said that rarely have you seen a workforce that is more miserable than the NHS. So how are we going to reform the use of agencies in the NHS without losing skilled staff who just want to work more flexibly?
I don't know how to give a less glib answer than you have to change incentives in the culture so that people don't want to go to agencies. I'm not sure what else you can say. That it seems to me that the entirety of the way in which the NHS is structured for people, even leaving aside pay, is rigid, hierarchical, overly structured in ways that no other profession would consider possible, let alone acceptable. And you have to change that.
Thank you. I will one more question here, which I will put to you, which is what kind of reforms do we need to consider for people living with multiple long-term conditions to improve their outcomes and experience of healthcare?
I mean, where does one begin, really? I think, and in some ways, I think if I could give a simple answer, it would be the wrong answer to that question. People's needs are different as individuals and across conditions. I think the free shifts identified are very broad, but need to be, because we're talking about changing model of care to basically deal with individuals with very, very different requirements. So if there was a one-size-fits-all answer, it would be the wrong answer.
Thank you. And that's actually given us time for one more question. I will take one more question from the audience. I'll take this lady here. But make it a very quick question, please.
We'll make it as quick as I can. India Hardy from PwC. So we spoke about there being a different offer based on incentives and otherwise for our providers and their participation. But talking about evolving this movement from state-owned to consumer-owned model, are there going to be differences at that end as well, based on need, on capability, or otherwise?
Paul, I'll leave that to you.
Yes, and we live in a deeply unequal society, and the inequalities are in every area of our lives. Agency is one of them. So different people have different agency, but one of the ways in which people do not develop their agency is because of the way in which a health service treats them. So this is not, he stresses, the only way in which agency can be developed. But we have sort of 18 million people with long-term conditions who actually have a relationship with a health service that could increase their agency or could decrease their agency. And if their agency is increased, and they are, as was just said, they're all different sorts of people, but paying attention to what is meant by their agency and their agency and their agency is enormously in the interests of the health service. Because if you increase their agency, you increase self-management, their capability. So being specific about agency creation and recognising it's a part of there used to be a thing about a dozen years ago called teachable moments. which is actually what do you say to somebody at a crucial... I'm very sorry you've got to have an operation, and perhaps you might give up smoking. That moment, and we've learned a lot in the last 5 or 6 years, I'm very sorry you've got diabetes. You can now reverse it if you go through a really vicious diet you wouldn't have done yesterday because you didn't know you had diabetes. So we have got agency building moments and the recognition that there are different aspects of people's agency. And again, to underline the point, health isn't the only thing that needs to increase people's agency.
Thank you. On that note, I'm going to bring this discussion to an end. I know there are many, many more questions, and I'm sorry we didn't get a chance to go through them. I would like to thank our 4 fantastic panellists for what's been a really fascinating discussion, Novartis for supporting the event, and everyone who has watched in person or online. Thank you very much.